Hello, I'm Andrew Pollard. I'm the director of the Oxford Vaccine Group, and I'm going to do something which I don't normally do, which is try and predict the future. And a good place to start is in the past. It does seem an enormously long time ago that we first heard about the outbreak of pneumonia in China. The first case reported outside China in the news was on the 14th of January 2020, just a few days after the first genome sequence of the virus arrived here in Oxford. But that does seem a long time ago. A lot has happened. We've been very heavily involved in the vaccine development, taking the Oxford vaccine from a gene sequence through manufacturing, phase 1, 2, 3 clinical trials, and finally authorization of the vaccine at the end of 2020 in an 8-month process from the first dose going into humans in the phase 1 trial on the 23rd of April through to the authorization by the MHRA in December. And that started a really important cascade of events with the approval by the European Medicines Agency and then finally by the World Health Organization, which allowed the global distribution of the vaccine. And at this point, particularly by the distribution through COVAX, you can see here on this slide, 243 million doses of various vaccines have now been delivered to low and middle income countries through COVAX, and the largest proportion of those doses from our vaccine developed here in Oxford. But there are a wide variety of other vaccines which you can see on this slide from the New York Times. The Oxford vaccine is the most widely distributed, followed by Pfizer and some of the Chinese vaccines, Moderna and the Russian vaccine. So a lot of vaccines now out there being deployed around the world at this moment. Now, here in the UK, we know already that this has had the most dramatic impact. Over 100,000 deaths in the recent reports have been prevented in the first 8 months of the year by the vaccine programme. And that is on the sort of scale that we would expect to have occurred based on the initial modelling. We would expected between 300 and 500,000 people to die in the UK without a vaccine. And if you add these 100,000 to the 130,000 that have died in the first 18 months of the pandemic here in the UK, we're already getting into the sort of numbers of potential deaths that there could have been, and you can really start to feel the enormous impact of the vaccine. Just imagine where we'd be at this moment without immunisation. But we've had a lot of concern about the variants that have been arising, and around the world people have been focusing a lot on these variants and whether they are going to have a huge impact on our protection from coronavirus. But so far, effectiveness against severe disease and hospitalisation is maintained. We had early data here in the UK with the Alpha variant showing that whether it was the Oxford AstraZeneca vaccine or the Pfizer vaccine, we had these very high levels of protection sustained at the start of this year. When we look at variants emerging in Latin America, we still have evidence of very high effectiveness. And the Delta variant, which is the most common globally now, the vaccines have high effectiveness, over 90% against this variant. So far, the vaccines have really held up. So what is going to happen next? Now, we've been concerned that with the neutralizing antibody escape of the virus, so this is just a slide from Cell which shows that this is the original Wuhan variant, a strain isolated in Australia. But if you look across Alpha, Beta, Gamma and Delta, you see a fall in the antibody levels that are able to kill this virus. And important point of this slide is despite that fall in the neutralizing capacity of sera, we are still seeing very high levels of protection. So focusing on the laboratory data doesn't tell us about how well we're protecting people against severe disease and hospitalization. And so we have to continue to monitor hospital data to work out whether there is any problem coming in the future. Now, I put this slide up, but this is sort of modelling predictions of what might happen in hospitalisation here in the UK in the latter half of this year. Well, sorry, in August. And the reason that I put this here is it shows the huge uncertainty about what might have happened in hospital admissions when we go back to when these analyses were done in July. And what actually has happened is that we've had very small numbers of hospital admissions. We're actually down towards the bottom end of this range of possibilities of hospital admissions because the vaccines are working extremely well. And I think there's so much uncertainty about what happens next that all the models that can be developed at the moment are going to have a lot of uncertainty about what actually happened. Here, if we look at some various assumptions of what might happen in hospital admissions through the later part of the year, you can see there's a whole range of possibilities depending on the amount of transmissibility of the virus from from modest to very high transmissibility, suggesting incredibly high numbers of hospital admissions could occur. But again, we've not seen through August and into September anything like these rates of admissions. I'm showing that the predictions at the moment about what happens next are enormously uncertain. So if we look at actually what's happening on the ground at the moment, we've had these waves of disease. The first wave doesn't figure very much because we had very little testing, but here's the end of the year, beginning of the year wave, and here's the summer wave of disease that we're seeing at the moment. And when you look at these data, it's rather scary that there's so much transmission at the moment. And of course, schools are now back across the whole of the UK, and we're going to see a further increase in cases as a result. But what's very striking is that compared with the previous waves, there is a very small number of hospital admissions that are being documented. And the data that we have on hospital admissions is slightly complex. It doesn't necessarily refer to COVID admissions. It relates to the people who've tested positive recently. So some of the data that we see reported will include people who've fallen off a ladder or been in a road traffic accident. And so the actual numbers of people in hospital are rather lower than we're seeing reported. And the other thing is we're seeing that these are people who have much milder illness. They tend to be in hospital for a much shorter period of time. So not only are the hospitalizations far lower than the previous waves, they're much shorter, and the patients are not as sick. Of course, there are always some patients who are vaccinated and are sick, but the vast majority are not as unwell before if they've been vaccinated. And when we look at deaths, you also see that there has been a rise in deaths again with that health warning there that some of the data here are slightly complicated by the amount of testing, which means that if there's a lot of transmission, deaths from other causes will get coded as deaths from COVID. But the rise in deaths has not followed the huge peaks that we saw in previous waves. There's no sign at the moment that is about to change. So the data we have so far is we can't really predict exactly what the future looks like. There's a lot of uncertainty, but so far everything looks quite reassuring. I mentioned that we think that there may be overestimates of severe disease and death, but we don't know whether effectiveness could wane over time, and certainly there may be some subgroups at greater risk than others who we need to look at more closely. And of course, there could be new variants that emerge which escape more from protection. So looking first of all at persistence, we have good evidence that after the second dose there's persistence of immune response for more than 200 days, and we'll have new data before long looking at up to a year later to see how good the immune responses have persisted over time. But actually there is good evidence that compared with an unvaccinated population, we have a huge amount of immunity as a result of those 2 doses that most people have had. And even if that does wane, our immune system remembers that we were vaccinated, ready to kick in. And I think that makes me very optimistic that we're not ever going to be able to get back to the levels of severe disease that we saw before. Now the virus is evolving all the time. It's now transmitting in a highly vaccinated population all over the world, and it will throw up new mutations. So there is likely to be new variants which can transmit better in vaccinated populations. And the key question then will be if that fitness improves in a vaccinated population with son of Delta, will that spill over into more severe disease? My hunch is the answer is no, but I think we have to keep watching the data. We don't have absolute certainty of that. In order to reboot the pandemic and start from square one, you need to change the whole of spike protein, rather than these small numbers of mutations that you're seeing that are highlighted here. Now, the drivers of selection of new variants is increased fitness. Well, Delta is already amazingly fit and transmissible, but it may be that it could go further, and escape from human immune responses. So far, no evidence that the variants will cause a collapse in protection. So what about boosting? I mean, this is the big question of the moment. There is no doubt that if you give further doses, we'll increase antibody and T-cell responses if we need to. There's also good evidence from the laboratory that you increase the ability of the antibodies that we make to neutralize a wider set of variants, and possibly would also increase the duration of immunity. So there's some good immunological benefits. Timing's important. Boosting works better. This is from past knowledge. If you boost once antibody levels have dropped, so you should wait a bit longer, probably at least 6 months after you've had your second dose, because that gives time for more maturation of the immune response. So if we did decide to boost, sure, you'll have better responses. Wait longer, they'll be better still. But there is a lot of uncertainty about whether we need to boost. The yellow fever vaccine gives lifelong protection with a single dose. Conversely, tetanus and diphtheria vaccines, we need 5 or 6 doses for lifelong protection. So we do need to keep looking at the data. We don't quite know exactly where these vaccines sit. As I said, my hunch is that we're in quite a good place at the moment. But there could be some subgroups who need a booster, people with particular health conditions, maybe the frailest elderly. But it really is not clear if or when vaccines might be needed for boosting. There is also a question about de-risking the future. If you've got uncertainty, maybe we should just boost anyway to de-risk the future. Now, that isn't the way that usually we make policy, but it is clearly attractive politically to do that. And it might also make sense from a health perspective in the middle of a pandemic to do so. And these are the sort of complex discussions which are being had at the moment. When we look at the different subgroups, and you can see on the column on the left here, there's a whole list of groups of people who often suffer with a greater risk of more severe disease or of waning immunity. But so far, most of the data we have suggests that we've got very high levels of protection after 2 doses in most of those groups. But there will be some on the periphery who don't make good responses to vaccines. And there's a big question there about whether further doses are going to make a huge difference to those groups, or whether actually having better access to good treatments is what's really needed. If we do need to boost, as I said already, we know we can boost. Here's some data showing with our vaccine that when you give a 3rd dose, you get an immune response that takes your antibodies up to a higher level than you had after the 2nd dose or after the 1st dose. That's evidence that you can boost responses. It's also evidence that the immune system remembers and so shoots up with a higher response. And that improves the level of antibody against these various variants. Here's alpha, beta, and delta on this slide. So you can boost the vaccines. Boosters expand the neutralizing capacity of the serum, improves immune responses. In fact, with our vaccine, you also have lower reactogenicity, so you don't get less symptoms with a 3rd dose. But the main question is whether boosting denies first doses elsewhere. If we suddenly start boosting the whole of the developed world, all the rich countries, we're going to be taking doses out of the system that could go to countries where people have 0 doses. And this is really important at this moment. We have rising cases in some parts of the world, particularly in Africa and parts of Asia, and as you know, also in North America, although the supply of vaccines is not a problem there. And so there's a 3rd wave of disease going on at this very moment, when we really need for those countries which are currently unvaccinated or have very low levels of vaccine to make sure that they have doses. And as you look around the world, you can see that at this moment, the place that is the shortest of doses of vaccine is Africa. The line right at the bottom here, the smallest number of doses per 100 people in the population. Europe is winning in this race of vaccinating the adult population, and Africa is trailing far behind. It isn't as simple as I've just presented. It isn't just a case of, if you've got booster doses, give them to a 50-year-old or a 60-year-old in Africa rather than a third dose to someone in the UK. There's a whole supply and distribution. There's the contracts about what you're allowed to do with the vaccines, and there's the expiry date of the vaccines. If you've got vaccines in the UK which are about to expire, getting them to another country before they expire is extremely difficult. All of this has to be put into the mix to try and work out what's best to do domestically for our population. And so far, there isn't strong evidence for boosting, but there might be some subgroups who would benefit. And then we have also this wider question of how do we protect the rest of the world and make sure that we don't end up with a situation where we drive further inequity by persuading the whole world who already have doses to give more, and those who have no doses to wait even longer. Thanks very much for listening. And I'll just end by acknowledging the various colleagues around the world who have been involved in our vaccine development, and the team, particularly here in Oxford, who have been absolutely amazing and still are in working on developing new variant vaccines, to supporting the many government studies which are being run across the UK to help inform some of these difficult questions going forward. Thank you very much.